So if there's a patient who clearly could benefit from the knowledge of the R score, but could not afford the Oncotype DX study assay, what would you how would you guide your decision making?
If one is in a country where the Oncotype DX is not available and possibly the 70 gene assay MammaPrint is available, or even PAM50, I still think that there could be utility of the assay, but it's important to remember, even for the MammaPrint assay, it's not just the score itself, it's also the incorporation of clinical risk. So if you're ordering that score, you should still be thinking about, is this a high clinical risk, low genomic risk patient, or vice versa? If one doesn't have access to any scores, then I think we really fall back on standard clinical and pathologic features like grade, like Ki-67, like tumor size and nodal status. And then we have to utilize our best sort of guess about what to do. The benefit of of a genomic score is that there's a standardized way of looking at tumor biology. However, there are costs and limitations that can come. And so in which case I would utilize some of those features to help determine risk, because even in the early development of the Oncotype DX assay, grade was an independent indicator for how patients did.